So good evening, everyone. Welcome to our 10th e-class. And today is a special one because now we go to the basics of the interventional cardiology, that is coronary angiogram. We have two distinguished and eminent cardiologists with us. We have Professor A.C. Nagmani, madam. She's a professor and unit chief in Sri Jayadeva Institute of Cardiology at Bangalore. And we have Professor Harsha. Harsha Basappa sir is again professor and unit chief in Sri Jayadeva Institute of Cardiological Sciences and Research in Mysore branch. So I welcome both of you to our e-class. And we have with us Dr. Jyotsna madam. So she's a professor of cardiology, presently retired, and she's the founder director of our Wincars Association. So I welcome all of you to e-class today. So let us now start with the talk. So this is by Professor Nagmani madam, and she'll be speaking on coronary angiogram, basics, techniques, views, and anomalies. Ma'am, over to you.
Thanks, Hema. Thank you for this opportunity. Actually, it is a big topic, and I will be covering only the basics. I think for all the seniors, probably this will be boring. Please stop me if I exceed time.
No problem, ma'am.
Let me get started.
Yeah.
Good evening, everyone.
For seniors, I think it is a revision, madam. So it is going to be very interesting.
Yes, ma'am. Good evening, everyone. When we look at the history of coronary angiogram, the first selective coronary angiogram was done more than 50 years ago by Dr. Mason. And this happened accidentally when he inadvertently injected contrast material into the RCA in a valvular heart disease patient. The patient had asystole for approximately 5 seconds, followed by sinus bradycardia, and he recovered with vigorous cough. Once this was described, then came the Sohn's technique, where arteriotomy was done for a brachial artery, and more thicker and rigid catheters were used to cannulate the coronaries. This was all refined by Judkin's technique, where the major modification was introduced by Judkins, a radiologist. And the first percutaneous transfemoral approach was done in 1967 using the modified Seldinger technique, and which is now called as a modified Seldinger technique. He used straight catheters and inserted stillets into them to form curves with them through trial and error. And he created the most appropriate shapes for reaching the ostium of coronary arteries. As reported in Registry of Society for Cardiac Angiography and Interventions in more than 2 lakh patients over a period of 42 months, where a mortality of less than 0.1% was reported, and coronary angiogram was labeled as a safe procedure in experienced hands. And we have come a long way from that period. So what are the goals of angiogram? We need to safely engage the target coronary artery in a coaxial orientation while providing optimal support. By this, we examine the entire coronary tree. We know the pattern of arterial distribution, anatomic or functional pathology, presence of collateral connections. So one needs to prepare the patient for the angiogram, and informed consent is very, very important. We need to explain the risks and the benefits of the procedure to the patient and the patient's attendants. A detailed history and physical examination is a must. Sadly, this has not been happening with the present day residents we have. Many a times, cath lists are done sitting in the chamber. That is a very bad trend. One should know the comorbidities which they have, their renal function and the anticoagulation status. the presence of peripheral arterial disease, which may guide us regarding the access we choose, a history of contrast allergy where we have to take precaution, and the history of previous procedure is also important. And we should ensure that comorbid conditions like a heart failure or renal insufficiency is stable. A few investigations are a basic before we subject the patient for angiogram, like a baseline ECG, creatinine and the electrolytes, complete blood count, where we know the presence of anemia or thrombocytopenia or any evidence of infection. Then coagulation profile, especially if the patient is on anticoagulation, it's a must. When we attempt femoral puncture, INR should be below 2. We should ensure that if we are doing an arterial puncture by femoral route, a radial route, INR up to 2.5 is accepted. Especially when we take the patients for rescue after thrombolytic therapy, the radial route is always preferred. It is better to ensure fasting for at least 6 hours, but we are not very strict with this. But before starting the procedure, see to it that intravenous line is established. Pre-medication is optional. If somebody is very anxious, maybe we can consider it with a small dose of midazolam or benzodiazepine small dose the night before the procedure. Adequate hydration is very, very important in presence of renal dysfunction. And this depends on the ventricular function and the baseline fluid status. Adequate local anesthesia is also very important to ensure that patient cooperates and the procedure is pain-free. When we are doing femoral puncture, the skin neck is very important. This is to facilitate insertion of sheath. And when there is any vascular bleed, it can ooze through the neck rather than be hidden in the form of a deep hematoma. The femoral access, one of our postgraduate, when he presented, he listed the 15 steps. I would like to, highlight on the two things: the femoral puncture needle, 18 gauge needle, and the short stiff wire is 0.035. Unfractionated heparin is commonly used. If you are using a heparinized saline, it may not be required at all, or you can use up to 1,000 to 1,500 international units. For the radial artery access, we are using micropuncture needle 22 gauge or a 21 gauge stainless steel needle. We use a hydrophilic wire here, 0.018 to 0.025. 5 French or 6 French. 6 French is the maximal which we can use with the radial. And we need to use a higher dose of heparin, 5,000 international units. And cocktail, a combination of NTG, verapamil, and diltiazem is a must, as the radial arteries are prone for spasm. So puncture at correct site should be ensured. This facilitates vessel entry, and it is helpful for effective compression to minimize local vascular complications. So the vascular access which we choose depends on the operator and the patient preferences, the anticoagulation status of the patient, and the presence of peripheral vascular disease. Suppose PVD is there in lower limbs, we tend to choose the radial artery. And patient nowadays are demanding the radial procedures, and even the interventionists are more familiar with the radial, especially the younger generation are more familiar with the radial artery access. The radial artery access has its advantages because it allows early ambulation, and there is improved patient satisfaction and comfort. Hospital stay is also reduced, and the greatest advantage is there in the reduced risk of bleeding complications. But technically, it is more challenging. Cannulation is more difficult. Whereas with femoral access, technically it is easier, but access site complications and patient discomfort are the main disadvantages. And there is also delayed ambulation. So in the last 10 years, The radial artery axis has taken over the femoral artery axis. So where do we puncture the femoral? It's the anterior wall of common femoral artery, which should be punctured 1 to 3 centimeters below the inguinal ligament, but proximal to the bifurcation. So inguinal ligament should serve as the landmark, not the crease. Inguinal crease can be misleading, especially if the patients are obese. The distance between the skin puncture site and arteriotomy site is significantly affected by body habitus. It is shorter in thinner patients, and in obese patients, we need to go full length to get the puncture. So puncture site is so very important in femoral artery axis, because if it is at or proximal to inguinal ligament, our catheter advancement becomes difficult. Hemostasis is also difficult, and there is always risk of retroperitoneal bleed. What happens if the puncture site is distal to bifurcation? We may not be able to enter the arterial lumen. There is higher risk of pseudoaneurysm formation and higher risk of thrombotic occlusion. So what is this CAMPU paradox? Because nowadays, the present generation interventionists are more familiar with radial. And when there is a need for switch over to the femoral, they really struggle. And what we see with the radial puncture is that there is difficulty in compression later on, and we are seeing more of access site complications. So the benefits conferred by radial access for cardiac catheterization are offset by a paradoxical increase in the rate of vascular access site complications with femoral access. This is described as the CAMPU radial paradox. Then next comes the introducer sheath. It is specified by the French number of the largest catheter that passes freely through the inner diameter of the sheath rather than its outer diameter. So 1 French unit is equivalent to 0.33 millimeter. The introducer sheaths which we commonly use are 15 centimeter. It reaches the mid-iliac. If we use a longer sheath for tortuous anatomy, it is 23 centimeter. It enters the distal aorta. And introducer sheaths have a back bleed valve and a side arm port, which can be used to give intermittent injections, and the valves can be opened to bleed intermittently. And one should be aware of the color coding of the sheaths. We commonly use 5 French and 6 French. 5 French is coded gray and 6 French is green. 8 French is blue, and pink are 12 and 14 French. It's a good thing to know about the color coding. Then once we connect it to the manifold, tubing that is connected to the transducer should be turned off to the patient and open to air. So establishing the zero reference is also important before we start the process. So guide wires are the ones which the wires which are small enough to pass through the inner diameter of the introducer needle and the catheter. The common length of the guide wire which we use is 150 centimeter. The diameter is 0.035 inches, and the tip conformation is J-tip. In tortuous anatomies, we will have to use a soft tipped with a catheter support. We may need an angled wire with a stiff body when more support is required, and we may end up requiring a hydrophilic wires as well. Coronary catheters are made of polyethylene or polyurethane. There is either steel braiding or nylon or carbon fiber, which acts as a reinforcing material within the catheter wall. This is required to allow advancement. It provides an excellent torque control and prevents kinking. But as we know, with repeated reusing of the catheter, the torque can be lost and even it becomes prone for kinking. So it should be really tested before we introduce for angiogram. The catheters are mainly preformed catheters. The 4 to 8 French end hole designs are available. But the commonly used are 5 French and 6 French. They taper near the tip. This is done to minimize the risk of arterial dissection. Outer diameter of the catheter is specified by French units and inner diameter is smaller than the outer diameter. This we need to know because of the thickness of the catheter material. So how do we choose the catheter? The choice of catheter, how do we do it? There is a need to opacify the coronary catheters and cardiac coronaries and the cardiac chambers adequately. We need to adequately manipulate. We need to limit vascular complications and it should permit early ambulations. So if the catheter is larger, it allows greater manipulation and excellent visualization of the coronaries. But if the catheters are smaller French, they require more technical skill for manipulation and they have lower flow rates. So they have limited use in tortuous anatomy and large body habiters and high coronary flow states. So when you choose a catheter, you choose a higher French when you are dealing with tortuous anatomies in elderly people or in the presence of LVH or hypertension or aortic stenosis, you need a larger French catheter. Insertion and flushing of catheters is very important. Always catheter should be introduced over the guide wire, especially up to the ascending aorta or the left bronchus. This is to prevent the displacement of the aortic wall block. And after removal of the wire, it is to be connected to the manifold system. What manifold does is it permits the maintenance of a closed system during pressure monitoring, catheter flushing, and contrast injection. Always ensure that there is double flushing of catheter. And when you have difficulty to withdraw blood, there are the possibility that it may be aborting the wall of the vessel. So this can be rectified by slight withdrawal or rotation of the catheter. Please ensure that sheaths are also frequently flushed, especially when the procedure gets prolonged. And tip pressure should be displayed on the monitor at all times, except during actual contrast injection. Nowadays, because of the overload, even in our labs, we are asked to do angiograms without pressure monitoring. Sometimes, we are forced to do that. That is not the ideal thing to do. So then coming to cannulation, the goal of cannulation is to align the tip of the catheter in a coaxial fashion with the origin of the coronary artery. And we record a normal continuous arterial pressure waveform from the catheter tip before injection of contrast for vessel opacification. So the pressure should be looked into before each injection and after each injection to know whether there is any pressure drop or whether there is any bradycardia. So you should be looking at the ECG monitoring, looking at the pressure waveform, and there should be a good hand-eye coordination. That is very, very important. So when you have a damping, so pressure, this is the normal pressure curve. What happens when there is damping? There is significant drop in both systolic and diastolic BP. So you don't see any spikes or squiggles, peaks and troughs are effaced. And aortic pressure loses its dicrotic notch. So if damping occurs before you engage or cannulate the catheter, what should you suspect? Either there is air or clot in the catheter, or the catheter is kinked, or the tube is kinked, or the tubing is too long, or connections are loose. Suppose after cannulation, if you notice dampening, what are you going to suspect? It is either ostial spasm, or the catheter is against the arterial wall, or it is deeply engaged, or catheter may be a larger catheter and coronary artery is smaller. So it is occluding the vessel. These are the possibilities. The same possibility is There, when there is ventricularization, what happens in ventricularization is there is dropping diastolic aortic pressure. The triangular waveform becomes rectangular waveform. So what do you do when you notice damping or ventricularization? If you inject contrast, you are in trouble. It may lead to coronary dissection. When you know that the contrast which you inject is going to replace the blood, but it is not getting cleared from the coronaries, what it does, it can cause lack of contrast clearance and the myocardial steam. So there is reduced myocardial oxygen supply and it can result in ventricular fibrillation. So this is very, very important. What do you do when there is damping or ventricularization? One should disengage, aspirate blood from the catheter to remove any air or clot, try to re-engage, do a non-selective image to check for osteal disease. Suppose you are doing right shoot, see whether you have cannulated conus. And if you are suspecting osteal lesion, you can inject nitroglycerin, but this can be counterproductive as well. So how can you ensure high success rate for cannulation with minimal complications? For that, you should understand the variety of catheters available, how to manipulate the catheters. You adopt the catheter choice to the individual anatomy of each patient, and you may end up using a guide catheter when diagnostic is not successful in cannulating. The catheters are all preformed catheters. They mainly have a primary and secondary curves. If you look at this picture, this is the primary curve we are talking of, and the secondary curve is this one. When you say Judkins 3 or 3.5 or 4, we are looking at the length between the primary curve and the secondary curve. So if this length is 3.5, we say Judkins 3.5. If the length is 4, we say Judkins 4. So what are the injection techniques which we have to follow? Selective injection should be at an adequate rate and volume. It should transiently replace the blood contained in the involved vessel with slight but continuous reflux into the aortic root. If there is no reflux, we suspect osteal disease. If you give too timid an injection, there is contrast dilution or streaming. Interpretation of the lesion becomes difficult. Your visualization is not adequate. If you give too vigorous an injection, dissection or excessive blushing can happen. If you give a too prolonged an injection, contrast materials, they are myocardial depressants, they depress the myocardium, patient can have bradycardia. So how should we give injection or how should we inject? Injection velocity should be built up gradually during the first second until the injection rate is adequate to completely replace antegrade blood flow into the coronary ostium. Average of 7 ml at 2.1 ml per second for left system and average of 4.8 ml at 1.7 ml per second in the right coronary. In patients with occlusion, much lower rates and volumes are required. In patients with left ventricular hypertrophy, larger coronaries you expect, you need to give larger volumes and higher rates. The points to remember when you are injecting, not to start the injection before angiographic image acquisition to identify calcification or late staining of contrast. When the proximal coronary segments are fully opacified, it can be terminated, injection can be terminated unless we need to visualize collaterals. The cine filming should be continued till you start seeing collaterals or a venous phase. Injection should be managed in such a way as to avoid mixing of blood, and syringe should be managed in such a way to avoid mixing of blood and contrast. Because this is thrombogenic, non-selective sinus shoots should be discouraged. Even in the presence of a non-dominant RCA, sometimes selective injection is required to identify an important collateral, if source of collateral, if the left system has an occluded vessel. So how do we select the catheters? Catheter selection depends on various factors, the age of the patient, anatomical approach, access site issues, and width of the aorta and the coronary anatomy and so forth. So one should be aware of the anatomy, the left main, how it arises. And left main arises anteriorly from the left sinus. LAD arises in an anterior and superior position. LCX, posterior and inferior. RCA arises anterior from the right aortic cusp. And SVGs also arise from the anterior portion of the heart. This is all useful for our cannulation. But the ostia can have different locations. Ostia can have high, low, anterior or posterior locations. One should be aware of this normal variations. Even the orientation can be different, superior, horizontal, or inferior as shown in these pictures. RCA, only RCA can have shuffled crook orientation as you see in this picture. One should be aware of this. Commonly we engage in elbow view. The left sinus is higher as compared to the right sinus. So aortic arch is opened in elbow view. If the left sinus is anterior and the left main arises from this, and the right sinus is inferior, and this is anterior and this is posterior. One should have a mental picture of this. The right radial, which we commonly use, encounters 2 points of resistance. As we enter the aortic arch from the subclavian, we encounter the first resistance, where we can ask the patient to take a deep breath, or just a shrugging of the shoulder or turning the head to the opposite direction will help. And the next resistance is as we enter the ascending aorta. But in left radial, which is almost similar to femoral, there is only 1 point of resistance as we enter the arch of aorta. So even when we cannulate with the Tiger catheter, which is the commonly used, there is some we can encounter, which is not easy as in femoral. So there needs to be some manipulation, and definitely asking the patient to take a breath and hold the breath will definitely help. If the catheter is unstable, we have to ask for some maneuvers. It can get disengaged, especially in a patient with severe AS or hypertension. Catheters can be really unstable. Even in short and small aorta, this can happen. So here we have to push the catheter onto the aortic valve and loop it until it reaches the left coronary ostium. This maneuvers needs to be done to ensure proper engagement. If we are not able to engage with radial, we can switch over to extra backup catheter, which gives us support. We can engage either from above as shown in this picture, or make a loop and get a support and engage it from below. This can cause a deep engagement, gives a good support, especially when you are doing angioplasty. The JL catheters are pre-shaped to allow entry into the left coronary ostium. So this becomes more easy as compared to our Tiger catheters. So Dr. Judkins himself told that the catheters know where to go unless thwarted by the operator. So no points are earned for coronary catheterization when you are doing femoral route. When you have a narrow aortic route, either 3.5 or JL4 is preferred. So what happens when you use JL4? You are going down. But if you have a dilated aortic route, if the patient is tall or elderly, you need a 4.4 or a JL5. If you are using a smaller curve, so it just folds off in the higher ascending aorta. So some push-pull technique is also required, and you can ask the patient to take a deep breath to ensure, and some small rotations and push-pull is required to ensure cannulation. A shorter curve may be useful for vessels with superior orientation, and longer curves may be useful for vessels with inferior orientation. This is for a normal variation. So when we are not able to engage with the Judkins, we switch over to Amplots. So it's an excellent alternative. So Amplots is required when the orifice is too high, or whether it is too out of plane anteriorly or posteriorly, or it is required for very short left main or separate origin, or for superior takeoff. The only precaution to be taken is when we are removing the catheter, it should be advanced in the body to disengage the tip superiorly from the ostium. If we simply withdraw, it can result in deep seating and potential dissection. This is called the withdrawal paradox. For cannulating the right coronary, the JR4 is enough. We can successfully engage in majority. One should remember that damping and ventricularization are more common because of the smaller caliber vessel. There can be ostial spasm, there can be selective engagement of the conus, and there can be true ostial stenosis. And dissection and ventricular fibrillation are higher, even though the RCA may be normal. One should be very careful. Coming to the angiographic views, accurate coronary diagnosis requires that coronary injections are done in multiple views, because we need to see all the coronary segments clearly without foreshortening or overlap. X-ray source is under the table, and the image intensifier is directly above the patient. And the body surface of the patient that faces the image intensifier determines the specific view. The term RAO designates a view where the image intensifier is positioned over the patient's right anterior chest wall. LAO designates a view where the image intensifier is positioned over the patient's left anterior chest wall. Skew is the amount of angulation towards the patient head or foot. So cranial or caudal. So this is the anatomy. This is what we see from the RAO view and the LAO view. The anterior descending and posterior descending arteries lie in the plane of the interventricular septum, or whereas the right and the circumflex coronary arteries lie in the plane of the atrioventricular valves. One should know this. So in the LAO 60, one is looking down the plane of the interventricular septum with the plane of the AV valves in phase. In the RAO projection, one is looking down the plane of the AV valves with the plane of the interventricular septum in phase. What are the standard views? We have RAO cranial and caudal, LAO cranial and caudal, and the PA cranial. But one should remember that not all the views are required for all the patients. For a particular patient, we have to choose particular views to get information. For a normal coronary, if we are able to see clearly, we may just do 3 or 4 views. In a complicated coronary, we'll have to do more views to take treatment decisions. So how do we recognize whether it is caudal or cranial? In cranial, diaphragm is seen over the shadow of the heart. One general rule is that if we need to see proximal segments better, it's the caudal views which we require to do, and the distal vessel segments are better seen with the cranial views, as it is demonstrated here. So there are many views with which we can profile the left coronaries, but as I have already told, these many views are not required for a single patient. Caudal views are good for distal LM, proximal LAD, and LCX. Cranial views are good for mid and distal LAD, diagonal, septals, and ostial LM. So in case of overlap of branches, when you want to set it apart, we need to remember the LCX moves in the same direction as the image intensifier, whereas LAD and diagonal move in the opposite direction. So if image intensifier moves LAO, LCX will move towards the left of the chest. In caudal views, LCX is down and LAD is up, because in caudal view, your image intensifier is caudal. So LCX comes down and LAD goes up. So Areva caudal is the best view. This is the first view you do where we see the circumflex clearly. We can see the left main and the proximal LAD. The AP caudal almost provides the same information, but this is the most confusing view in case of total occlusion of LAD, because if we have a large diagonal, which can look like LAD. To get more information, we do elevocranial, where it can be clearly seen. This is the best view to differentiate LAD from large diagonal when LAD has total occlusion. And this is also the best view to identify when there is dominant LCX, because we can see the PDA very clearly. So this is the best view to identify dominant LCX. But this is not a view which is friendly to interventional cardiologists. Because we guessed the most radiation with this view. So Belleve caudal views, it's also called the spider view. We can see the left main and the ostia very clearly. This is the excellent view. And this view is best in patients with horizontal heart, but is bad in patients who have a vertical heart. So the epicranial view is the best for the LAD, where you can see the mid LAD and the distal LAD, but LCX is not clearly seen. RAO cranial is similar to PA cranial, but you can clearly see the proximal LAD and the diagonal branches. So what are the best views for the left main? It is the best will be the elevocaudal view, but especially for stenting, we prefer elevocranial, especially we are stenting ostial. Ostial left main can be clearly seen in the elevocranial view or elevostraight view. So what are the additional views? Like we have left lateral, again the radiation is more. This is good for proximal and distal LAD. Aravostraight view is similar to aravocaudal, and elevostraight views are similar to elevocranial. These views are particularly useful for interventions in obese patients because they reduce the blurriness induced by soft tissue and the diaphragm. So avoid steep angles in obese patients to reduce blurriness and radiation. For RCA, we use elevo. We can see the proximal and the mid RCA, but the bifurcation is clear when with the elevocranial view, it opens up the bifurcation points, but it foreshortens the mid RCA, which can be clearly seen in the AP cranial view. It is also excellent for bifurcation. So ostial RCA, if you need to further assess, steep elevo or elevocaudal is the best. So what is the story of missing vessels? I need another 5 minutes. Is it okay, Hema?
Yes, ma'am. 5 minutes is fine. Yeah, 8:50.
Yeah. Total occlusion, if you see, we miss the vessel. So what is happening is we need to follow up. The vessel may appear opacifying or the collateral filling from the other circulation, or if there is acute occlusion, they may not show any filling at all. So even though the vessel is patent, we may not see any filling. If there is anomalous origin from opposite sinus, when we don't see the vessel, we should search for the anomalous origin. It may not be truly anomalous, but a separate origin. Very rarely, a scarred territory may also show the scarred vessel. Graft angiogram is more complicated. You need at least 2 injections each for LCA and RCA in orthogonal views. Before doing a graft angiogram, always have an idea what grafts patient has received. 90% of the SVG grafts are hooked with the JR catheter. And hooking view is really important. Right grafts are hooked in shallow levo view and left SVG in shallow revo view, as we see here. And for Lima, one straight view, as we see here, and one good view for LAD, either a revo or levo cranial meso, anastomotic site, and the left lateral view, we can see the anastomotic site clearly. Coming to the anomalies of native coronary arteries, frequency is less than 1%. The commonest would be, I wouldn't say the commonest. We tend to encounter short left mains where we struggle to selectively engage LAD and LCX. It can appear like separate ostia of LAD and LCX. When there is separate ostia, LAD cannulation can be tried with JL3 with clockwise movement of the tip. LCX cannulation, you require JL5 with counterclockwise movement of the tip. LCX from right coronary ostium is another common anomaly we see. And LCX from right coronary sinus in 0.7% of population. Typically, proximal portion of anomalous vessel as an inferior pores and multipurpose catheter would be the ideal. LCA from RCA as is the least common anomaly. And the cannulation of right coronary artery, as we know, we always struggle to cannulate right coronary artery because the most common variations are with right coronary, would be high origin or the low or anterior ostium. And low ectopic origin and high ectopic origin multipurpose catheters are very useful. For anterior origin, catheters with a longer reach are useful. For anomalous origin of RCA from left sinus is around 0.9%, where the ostium lies anterior and superior. So you need to use a different catheter and different maneuver. Just to summarize, the technique of coronary angiography remains important in contemporary clinical practice. No didactic training can substitute for the hands-on experience. This all of us know. A thorough understanding of intellectual elements fundamental to angiography will result in a more efficient, effective, and safe procedure. Thanks everyone for patient listening.
Thank you so much, ma'am. It was a very lucid and very informative presentation, and I was transported to my PG days. So that's very effective learning, very much for all of us. And we shall go to the spotters where we can discuss much more. I request Dr. Harsha Basappa to kindly upload the spotters presentation.
Good evening. Am I audible?
Yes, sir.
Can I say a few things before we go to the spotters? Because I know a lot of young enthusiastic cardiologists now who think, angiogram is just a procedure. What I would always tell young cardiologists is like angiogram may be a procedure now, but with the development of skills and other things, it becomes an art. So every student of cardiology has to learn angiography proficiently. My boss used to always tell, a good cardiologist is one who can perform an angiogram without the help of a scrub nurse. So from the point of puncture to the entry into the artery and the exchange of catheters with the guide wire has to be an art. So how nicely or how fluently a person executes this procedure is important. So what I would always tell them is one thing is the delicacy of the procedure where they always have to glide the hardware, not push the hardware. Number one, any resistance, stop, think twice before pushing, number one. Number two is don't helicopter the catheters, especially when we are doing radial. Every catheter movement has to be delicate. So the more we helicopter the catheter, the more chances that we send the artery into spasm or raise a plaque if it is a femoral line. And knotting also is one of the issues which we keep facing these days because of erratic talking of aux catheters sometimes. With these few points, I know I can understand how Dr. Nagmani or we have learned angiogram, because even after passing my cardiology, we were not given independent angiograms those days. Now things are different. And as Madam told, pressure waveform and ECG are extremely important. The responsibility of the doctor who will perform the angiogram starts from the consent taking, explaining the procedure to the patient till the patient is discharged. It's just not the duty of doing an angiogram in the cath lab. So every complication which occurs in this process will the operator will be responsible for it. So this is what the youngsters has to learn. With that, I'll just project a few
Add
slides.
two, three
Dr.
comments,
Deepak is,
if you permit.
yeah, yes, ma'am.
Yeah, just I wanted to, Madam covered everything. The few points which are the important things to be added, just I wanted to say it. About the INR, as she said that 2 for the femoral and 2.5 for the radial is true, but nowadays, even for the femoral of the 2.5 is unacceptable when you are doing the micropuncture. That is the major thing, especially for the valvular heart diseases. Most of the time, the patients will be on an anticoagulation because of the other conditions like having a AF or the some other reason, LA clot or LA clot. So at the time it becomes sometimes mandatory to do the femoral. So that time, even without the discontinuation of the anticoagulation, it is advisable to do. But only thing is take a precaution if you're doing a micropuncture is a better one. And of course, the major problem with the radial, when the INR is a higher side, even though axis side bleeding is not there, but non-axis side bleedings can be then happen in that. So we have to pay attention, not only axis, non-axis side with INR in the higher side. Of course, radial side is, size catheters, Madam said 6 French. Nowadays, is 7 French is used, and especially in the larger size radials, and in we have the sheath in sheaths. The radial guide catheters are there, so we can have the even slightly bigger one. And of course, the sheath lengths, as Madam said, usually for the coronary, we 25 centimeters of the longer length, 23, and longer the 40 will be sufficient. But sometimes for other interventions like the PDA and all those things, it requires a 40, 60 centimeters length of the sheaths are also is available. And the testing of the integrity of the catheter is, as Madam insisted, is very, very important, because all our catheters are G catheters. Many of them we use it the G. So integrity to see before putting into the body is the most important thing to prevent the complications. That many of us doesn't do it. Sister puts the on the table the catheters we take and we put it into the art vessels. But integrity has to be the same. And of course, the manual injection versus automatic injection of the giving a contrast when you are doing the coronary angiogram. Automatic injection has its advantages and disadvantages. Definitely, the contrast load will be less if you are giving an automatic injection. But the major problem there is you can't have a control on the delivery of the contrast. That is a major. And the views in that, just I wanted to add, ostial left main, always we talk about the caudal views are the best. But when you start intervention, you realize that you will deploy an LMCA ostial stent in the cranial view, either the epicranial or the LAVO. And just I wanted to add these points to complete our extensive, excellent presentation. Yes, sir. Please go ahead.
Thanks for the points, Madam. Very relevant points, and especially for the juniors.
Yeah. We are running short of time. Please, sir.
Yes.
Go ahead, Dr. Basippa.
Thank you. Sir, please
We'll
upload
share.
yourself.
Okay, yeah. Without wasting much time. Well, just give me a second. Are my slides seen?
Oh, Harsha.
Oh, 1 minute. 1 minute. Is it seen now?
Uh-huh.
Ah. Dr. Deepak is here, who will just tell his comments for this slide. This is a pressure recording during a routine coronary angiogram. Deepak, can you just tell what you see and what would you have done in such a situation?
Yes, sir. Good evening, sir.
Good
Sir,
evening, good evening.
this is a normal arterial wave pressure tracing during normal angiogram. Initially in the first above slide, we can see initially first two waves are normal waves, and later on in the subsequent arterial waveforms, we can see that the diastolic pressure is decreased and the systolic pressure is maintained. So it is like ventricularization of pressure is seen during angiogram. Later, which is again followed by subsequent normal arterial tracing, sir. So and in the second slide, in the bottom slide, we can see that both the systolic and the diastolic pressures are decreased. It is like dampening is seen, and later on we can see a flat line tracing, but above we can see that ECG tracings are there. So it might be that the flat line is because of the contrast injection which we are doing, which we are giving for the which we are giving for angiographs. Later on followed by normal arterial tracing. So it is most commonly seen in ostial stenosis, where there is a where because of the catheter it is occluded and there is a pressure damping is seen.
Exactly.
This the
This is
panelist.
yeah, this is yeah,
Yeah.
this is a pictographic analysis, sorry, explanation of what you said. Exactly. Whenever there is an ostial lesion, what happens is the catheter tries to wedge into the lesion. So whenever during systole, because of the cardiac contraction and the ejection of blood, the catheter slightly moves away from the lesion, and we can record normal systolic pressure. But what happens during diastole is the catheter usually gets sucked into the vessel because most of the blood flow during into the coronaries is during diastole. This is the time when the catheter goes and wedges into the lesion. That's when the pressure dampening occurs. Sometimes we may think that we are inside the left ventricle, but this is ventricularization and one of the very dangerous hemodynamic complications which can lead to ventricular tachycardia and dissections of this particular segment. So in the second graph, what we saw was this something called a hit and run technique where it is better to be we have to exhibit extreme caution during such situations where the injection has to be gentle but stable, where moment the catheter sits into the region, just inject a few ml, define the anatomy and come out. Don't wait for things to happen. This is the angiogram, this bladder fluoro of a patient who was taken up for a femoral angiography, and the patient complained of abdominal pain. Can you just say what's happening here?
Sir, it might be a retroperitoneal hematoma, a complication which is commonly seen in the femoral puncture when it is done above the level of the inguinal ligament, so that blood is leaking, and it is forming an hematoma and causing some compression over the abdominal this organs, mostly some bladder, because of which the patient complains of pain, sir.
Yeah, exactly. I'll just go to this picture where what you can see here is whenever there's a high femoral puncture, there are chances of retroperitoneal hematoma. As you know, retroperitoneum is a huge space, and to identify for the somebody to develop classical signs takes time. And moment a patient complains of right abdominal pain while doing an angiogram or during the post procedure, what we have to first think is retroperitoneal hematoma. One of the best way of eliciting it is deep penetration, sorry, deep palpation in the right iliac fossa. If you palpate deeply, patient do complain of tenderness. So here what you can see is the angiogram is being done. As you know, once the angiogram procedure starts and we inject the dye, within few minutes, the dye gets collected in the bladder. So here what's happening is in the superior margin of the bladder, there is some irregularity or impingement which is caused by the retroperitoneal hematoma. One of the thing high suspicion is required, and this is the algorithm of management where if the patient is stable, we should ask for a CT scan because abdominal ultrasound is of not much use. If the patient is unstable, take the patient for CAT immediately. What I always suggest is most of the time in a high puncture, when patient has hematoma, it's usually a perisheath leakage. First thing I always do is upsize the sheath in the femoral artery. If somebody has put a 7 French sheath, take a new 8 French sheath, upsize it immediately, the bleeding will stop provided it was a neat puncture. Most of the time, if there's a posterior puncture, then it's very difficult to control. Best thing would be take the patient up for angio and you balloon seal it, and the rest of the procedures is given here. Coil plugging I have not done. We have seen procedures like wall stent being used or balloon sealing being done. One or two bad experiences, whatever I have had, I have managed it with balloon sealing. So this is angiogram because the angiogram is part of angioplasty where patient was taken up for angioplasty, and what we realized was something funny was happening with the lie of the guide wire. Can you please tell what's happening here, Deepak?
Sir, this is means we can see a faint this means
We,
we can see
in,
in between the guide wire and between this vessel we can see a faint dissection like thing, sir.
radiolucent spiral. In the interest of time, I'll
Radiolus.
just yeah.
Yes.
See what we can see here is I'll keep playing it. There's a radiolucent space between the wire and the vessel wall. And what I have done in this particular situation is taken the second wire. Okay. So what exactly it is, here the wire has entered the false lumen and come back into the true lumen. Even though the true lumen wire entry is a standard procedure in situations of chronic total occlusion, sometimes what happens is when inadvertent advancement of the wire or there may be some dissections which we enter, the wire itself without our intention will go to a subintimal space and go back into the true lumen. So what happens is, what is the finding is here is the false entry of the wire into the false lumen. How we identify this is, number one, in the first step, what we have to do is when we torque the wire inside the vessel, if the tip movement is restricted compared to what we observed during the initial phases of the wire advancement, that means wire is in a place where there is no movement. Most probably it is in the subintimal plane. And the second thing is how to identify in a vessel if the wire is in the true lumen or not. Is one is when the wire easily goes into a septal branch or or a side branch of the vessel. That means most of the time we are in the true lumen. Number two. Number three, if the movement of the wire into a small branch induces chest pain because of epicardial irritation or an ectopic, that means we are in the true lumen. So how do we manage such a situation is what we have to do. The moment we identify this, we have to leave the wire there, take another wire and delicately try to advance it with minimal torquing and minimal trauma to the area where there is dissection, and try to park the wire in the nearest side branch, which will will be 100% sure that it's a true lumen. Rest of it will be like stenting and other things. Okay. So what's happening here? This is a pressure tracing, one of the very classical textbook descriptions where I have taken a screenshot. Can you just tell Deepak?
Sir, in this pressure tracing, we can see that there is a systolic gradient is seen between the in between aorta and left ventricle. So that is suggestive of some outflow obstruction is there. So as compared to in the first graph on the left side, we can see that in the aortic tracing also the aortic peaking is in the late phase of the systole. It is suggesting of parvus attardus, and the LV gradient is having a rapid upstroke and rapid fall is there, sir. It is suggesting of some fixed obstruction. And in the second, in the on the right side, in the aortic tracing, we can see a spike dome pattern is seen, sir. And even we can see that in the left atrial pressure is also increased. So it is mostly some dynamic obstruction which is seen, sir.
Yeah, correct. This is one of the classical textbook description and the graphs what we have already seen. So in the interest of time, I'll just run through this. Only thing is the pulse pressure what we have to see. This is a classical Brownwood phenomena. This slide is self-explanatory where the left picture shows pulses tardus at tardus. And the right one is a dynamic obstruction.
So we are extending the talk for 10 more minutes. Yeah, so just so
Okay, I think I don't think we require so much now. Okay, this is one of the recent angiograms what we saw. I keep playing it. It's can you just tell Deepak what you're saying so that we can
Sir, it's
go forward with the
a
discussion.
it's a very tortuous LED vessel, sir, which is draining into some coronary chambers, sir. It may be coronary sinus in which it is draining, sir.
Yeah, this is anomalous drainage of the left anterior descending artery. When I saw this case and saw the literature, it's one of the extremely rare coronary malformations where the coronary artery, the left anterior descending artery, drains into the coronary sinus. Okay. So this was a patient who had doubtful positive TMT for whom we did a CT scan. The CT scan showed extremely tortuous left anterior descending artery. So we did a conventional angiogram just to decide, just to understand what's happening, and this was the finding. Since the patient was asymptomatic, on the whole, we are continuing for medical management. And percutaneous intervention in this patient, I feel it's not a good idea because if you see the extreme tortuosity of the distal left anterior descending artery or towards the tip, I don't think we can venture into plugging this vessel without causing any trauma to the left anterior descending artery. The next is the last one.
I invite the other panelists also to kindly give their opinion on the previous spotter.
So what's happening here in the mid segment?
So
Sir,
I would like to ask the other panelists to kindly give their opinions also. Shall we, Josna ma'am, would you like to say anything about the previous spotter?
Previous spotter, what is described is a tortuous LED and draining into the coronary sinus. This is to confirm that another view is also required, that is whether coronary sinus or not. Because unless we see the branches of the coronary sinus, we can't be very certain. And the position has to be the confirmed that it is in the LAO view, it is crossing to the spine definitely to the coronary sinus. That's what the first thing. Second one is whether it requires a treatment or not. Usually LED, it goes to the tissues. From the tissue, it has to drain into the coronary sinus subsequently from the venous phase. Now, because of this fistula, directly arterial blood is going to that of the coronary sinus. So it is worth seeing whether ischemia is producing this by this or not. If it is producing an ischemia, then it is requires a treatment, or otherwise it is not required. Otherwise, the drainage is either through the capillaries draining to the venous system to the coronary sinus or directly to that. So it makes a difference whether it is producing ischemia or not.
Thank you, ma'am. Nagmani ma'am, would you like to concur?
I just wanted to know, like, suppose patient were to be symptomatic, what procedure we would have offered him? Maybe Dr. Usha also can take it up.
Madam, only worry for me is the extreme tortuosity of the tip of the vessel after the apex. So if we plan for any device closure or a vascular plug, it's extremely difficult for us to go through this tortuous segment. Reaching this from the right side of the heart, I don't know. I'm not read anywhere.
That's the reason I asked Usha. I don't know whether she's there.
Yeah, hello, ma'am.
Hello, Usha.
Usually, what we see, congenital fistulas, they can often drain into coronary sinus. And most of the times we close the fistulas from the venous end only. But here, only problem will be making a AV loop because of the extreme tortuosity of this LAD. If we are able to enter directly into the CS without an AV loop, we'll be able to close this. But is there an indication for closure of this?
No, ma'am, no.
Asymptomatic. What was the indication for angiogram?
Ma'am, what happened was, as usual, like most of the time when they come to OPD with chronic atypical symptoms, the TMT was done, which was showing some upsloping ST depressions.
Okay,
And it
TMT
was,
positivity.
yeah,
Oh.
yeah, and then because it was not,
Oh, what
it
was
was
the
false
age of the
positive.
patient?
This patient is around 50 years, ma'am.
50
She's a
years.
female, not a diabetic or hypertensive, no other significant history.
No, there is a possibility that patient may become symptomatic later on.
Yes, yes, ma'am, yeah, that's what,
Yeah,
yeah,
we
if
should
there's
know like
any,
how to deal
like
with
something
it.
like, yeah, yeah, yes,
Yeah.
ma'am.
Yeah. Thank
Ma'am,
you, everyone.
this connection
The last
is so
spotter.
small. Would it cause steel? It is so
We don't
tortuous.
know. Yeah, yeah, may not be causing steel, ma'am. It may not be causing the coronary steel.
Right, right.
This is a patient, young person who again had a positive TMT for whom we did an angiogram. What's showing here is a mid-myocardial bridge. I just wanted to highlight the necessity of having an electrocardiogram gated coronary angiogram pictures where most of the analysis what we do should not be done during systole, it should be done during diastole. During systole, what happens most of the time, a non-significant lesion can also be wrongly interpreted as a significant lesion. So this is one of the examples where we should be very careful when giving a diagnosis of significant lesion, and we should always look at the ECG also before we kind of give a decision in borderline lesions. So these are only the 6 slides which I have. So whenever I get into the cath lab and see these complex cases, I remember a few words of my boss who used to always tell in the cath lab we should be like Ravana, think in 10 different directions, monitor 10 different things, and be ready to perform 10 different tasks in case if there's an emergency. So I always tell a cardiologist should have a lion's heart, an eagle's eye, and the fingers as delicate as a lady's finger. Thank you, ma'am.
True.
There
Thank
is
you so
one
much, sir.
question from the audience. I
Yes.
think they've asked question number 5. Kindly elaborate.
Question number 5, kind of, or a slide, ma'am.
Yeah, I think the 5th spotter which you had shown.
Fifth spotter is that AV fistula, arteriovenous fistula. Or
Yeah, I
the
think we
slide 5
had enough
was
discussion.
the wire in the false lumen, which went into the true lumen again.
Okay, there are no further questions. Hema, I think you can conclude the session.
Yeah, I'd like to thank everyone. Thank you. Thanks to our resident also, Dr. Deepak Gupta. I thank Nagmani madam for her very beautiful and lucid presentation. I thank Harsha sir very much. Lovely spotters and very good discussion. Jyotsna ma'am, thank you so much for adding your valuable comments to all of our e-classes, and this e-class especially because it's very close to all interventional cardiologists and all cardiologists per se. So thank you, Dr. Usha and Dr. Rupali for conducting the e-class with me. And I thank Medgami for hosting this e-class. So thank you, everyone. And very good discussion and have a great night. Good night.